Extension of my talk on the hip assessment or hip examination. Again, I would like to point out that this activity is through a Shelby PG course, supported by Shelby Hospitals, mainly for the postgraduate activity. These are some couple of special tests and a few other things we will discuss. This is a Galeazzi test, which you keep the knee at 90 degrees, hip maybe at 60, 90. I think most of the time it is described in the book is about 90 degrees of hip, but here the hip doesn't look to be, it is only at 60, 65 degrees. And keep both heels at the same level and look at the level of the knee. If there is a shortening in that limb, suppose the left side is short, the knee is on the higher side and the right side. That indicates either it is a dislocated hip or there could be a possibility of malunited femur, malunited neck, couple of things which are there. Either it is a supratrochanteric, even infratrochanteric can realize there is a limb length discrepancy in the femur. Tibia looks to be equal if you look at the most of the time. The knee level goes down, but the tibia, if you measure that, tibia will be equal on the both the side, but only on the femur side it will be. So it is a segmental shortening on the femur side, which is a Galeazzi. But the tibia is almost same. Then the telescoping test. This is also for a dislocation, mainly for the adult. We do this test. And the children, we will see that the other tests are described for the children. So flex the hip to 90 degrees. And this for important is that you require a good amount of flexion at the hip. If the hip is stiff because of the post-acetabular fracture or something dislocation, the stiffness is there, even though that hip is dislocated, you may not be able to get into 90 degrees. So you require good mobility at 90 degrees, then only you can perform this test. So flex the hip to 90 degrees. One hand with thumb is on the anterior superior spine. We are stabilizing that pelvis. You are stabilizing the pelvis on the finger over the soft tissues in the proximal femur. Then the other hand is on the distal femur. That is not at the tibia, but maybe just at the level of the knee, at at 90 degrees, just proximal on the proximal side of the tibia, not on the femur. You can't hold the femur, so you have to have a knee also at 90 degrees to hold that upper end of the tibia, and then push and pull the femur. That is the way it has to be done. Suppose patient is slightly heavy and you are not able to, then what you should do, ask one of the assistant to support the pelvis, or you have to stabilize the pelvis and ask him to look at the trochanter or whatever the head, whatever the remaining part of the proximal femur, and you do it gentle you use both hands on the proximal tibia and try to do it. There is a possibility of giving one heavy patient, but most of the time you should be able to do it yourself. And there is abnormal mobility with a push and pull that indicates the hip is unstable. So that is a telescoping test. Test for Barlow's manure. And Ortolani. There are two different tests. Barlow is slightly different and Ortolani is different. How do you differentiate these tests are? See, Barlow, the maneuver is easily performed by adducting the hip while applying the light pressure on the knee, directing the force posteriorly. In this Barlow, if hip is dislocatable, that is, if the hip can be popped out of the socket, with this maneuver, the test is considered positive. So it is dislocating the hip. Barlow is a dislocating hip, Ortolani is a reduction. So that is the way you have to keep in mind. So the Barlow, you are adducting. and trying to take out the hip from the position from the acetabular is a dislocatable hip. And Ortolani is a procedure where you want to relocate. So we are in Ortolani, we are abducting and rotating the hip. Here we are not abducting, we are adducting the hip in Barlow. So there's a gross difference between the Barlow and Ortolani. So Barlow is a dislocating hip. And Ortolani is performed by examiners first flexing the hip and the knee of supine in infant 90 degrees, then with examiner's index finger, placing the anterior pressure on the greater trochanter, gently and smoothly abducting the infant's leg using the examiner's thumb. So you are trying to reduce that. A positive sign is distinct clunk, that is, which hip was dislocated, which will get reduced inside, which can be heard or felt on the femur relocating anteriorly into the acetabulum. So again, Barlow is you are dislocating the hip, and Ortolani you are reducing the hip. That is the difference. So this is what the feeling is. This is your feel a clunk, not to hear a click. And a reduction, this is reduction maneuver. Yes, sir. Reduction maneuver in abduction and pushing with the thumb and index the hip inside. That is the way, the two differentiation between Barlow and Ortolani. Most of the time, examiners will try to pull your leg. So be firm, very clear. Barlow, you are adducting and dislocating the hip. Ortolani is a reduction maneuver. Ortolani is a reduction maneuver where you are abducting and pushing the hip inside anteriorly. So that's the way you differentiate. That's Barlow. Okay. This we discussed last time regarding vascular sign of Narad. So here, anyone can tell what are the conditions where vascular sign of Narad is positive? Anybody?
Yes, anybody?
Resident?
Dislocation of the hip, sir. Positive dislocation of the hip.
Yes, one. Yes, one.
Resorption of the femoral neck.
Femoral neck resorption.
Yes, next.
DDH, sir.
That is already there, dislocated.
Yes, sir.
Central fracture dislocations.
There, yes, possibility is there, but still something underneath the femur will be there to palpate. Okay.
PFFD, sir. PFFD. Proximal femoral deficiency.
Yeah, proximal femoral deficiency. Yes, possibility. Anyhow, these are conditions where you get an excised hip already, dislocated, traumatic injury, vascular conditions, couple of things are there. So sometimes in an excision hip where there is nothing there. So that is one procedure, and traumatic injury of vascular injuries are possibilities. Another possibilities are there. So these are a couple of cases not there. So that will that will be the main idea. Then we go to the Ober's test. This is mainly for a tightness of the iliotibial tract. So this test, iliotibial tract contraction, put the patient in lateral decubitus position. Knee is flexed to 90 degrees, flexed to 90 degrees. Hip is in abduction to around 30 to 40 degrees of abduction. Pelvis is stabilized with one hand. The limb is gently adducted towards the other opposite side or a table towards the table. Examine the table. Normally, hip can adduct and the limb can cross the midline. So here, if it is a tightness of the TFL, we will not be able to do the knee will not go down in adduction. Instead of that, knee will go into flexion. The hip will go into flexion, and also knee will go into more of flexion. That is the Ober's test, which becomes positive. Let me go back. Okay. One, you extend the knee. You extend the knee and try to do this test. Try to do this test with an extension knee. You won't be able to, this hip, the hip will not go into adduction. You flex the knee to 90 degrees. You will be able to do this test in adduction. That is TFL. You can get the TFL gets relaxed as you flex the knee. As you flex the knee, again, very crystal clear. Lateral decubitus position. Keep the pelvis stabilized. Keep the knee in full extension and try to do this test. You won't be able to do anything at all. And then you flex the knee to release the TFL. Then you will be able to adduct the hip. And if it is too tight, then the hip will get into flexion. That's a very classical test of iliotibial bad tightness. Test for rectus contraction, that is known as the Ellis test. Rectus. Sometimes you get an isolated rectus contraction. We used to see them in a maybe about 15-20 years back with the post injection. Actually, a lot of injections in children used to get into the thigh. You know, most of the time the general practitioners, they used to use sometimes saline also. At that time we used to get a lot of contraction. Nowadays we don't see that type of contraction, but you can get congenital tightness of the rectus contraction is also known entity. How do we test this isolated rectus contraction? For the rectus contraction, make the patient prone completely, prone in position, and keep the knee in extension. Passively flex one knee to be tested. Normally, as you normally knee can be flexed with a fully, you can flex and the hip will be in neutral. But if there's a rectus contraction, hip gets on flexion, causing this, the buttock goes up, raises up. So again, prone the patient, flex the knee, which is you are going to examine, that is the hip, that is the side of the hip. As you flex excessively, usually if the rectus contraction is there, the hip will be flexed, that the buttock goes up. And also patient complains of little bit of discomfort anteriorly. It's a very classical test of Ellis test of rectus tightness. Usually it is, if it is congenital, it is usually bilateral actually. And another important sign in this patient is, very important sign, which you miss it. All rectus tightness bilateral have a lumbar lordosis because it's a compensatory mechanism. Any patient coming with a lumbar lordosis with other hip pathology, normal, movements are good, everything is good, and still has got a lumbar lordosis, and this is one test we usually miss. Bilateral rectus contracture leading to hyperlordosis because of the compensatory phenomena. The another test now is a flip test to detect the contracture of Gracilis. I think this test was described by, this is already talked to you by Dr. Dheeraj Ganjwala. This is in cerebral palsy. Was very important test he described, and it was a lot of detailed discussion was taken. But I am just repeating this test for you. The Gracilis contracture. Prone position with the knee extended. Passively abduct to maximum. Now you abduct maximum whatever you can with extended knee. Then the second, the figure is flex. Knees are then flexed to relax gracilis. Attempt to further abduct the hip with the knee in flexion. Further abduction is possible if there is a gracilis contraction. So there is a possibility of further abduction possible if there is a gracilis contraction. Again, I am repeating, make the patient prone completely, extend the knee fully, abduct the hip, whatever the best possible is. Then you flex the knee, and still there is a possibility of further abduction possible if there is a gracilis, because the gracilis is relaxed now. So there is reason is that you will allow to get another 10 or 20 degrees of abduction possible with a knee inflection. That is the gracilis contraction. It's very important test for cerebral palsy, mainly, for nothing else as far as. Then we have certain tests for femoral anteversion. There is a Craig's test. I think these are all gross tests, but I think many examiner may or sometimes they like this couple of tests are, but the ideal way to anteversion is something else, which I will tell you. So the test for femoral anteversion is a great test. Make the patient prone, position prone. This is usually we do it in the children. This is the test which is done in children because of for the anteversion, and especially those patients who are walking with an in-toeing gait. These are the tests which we will allow to do it. So keep the knee in flexion 90 degrees. One hand on the trochanter. That's a prominent part of the trochanter, and make it almost like a parallel to the floor. So you allow the external rotation of the limb as much as possible till the trochanter touches literally on the bed or what is examining couch, and then you measure the angle, a imaginary line on the right angle to the floor, right angle to the examining table and the tibial axis, and that is the angle of anteversion. That is the way it is described as a Craig's test, mainly for excessive anteversion. So you have to get an external rotation till you get the trochanter parallel to the examining table or a couch, and you do the tibia axis and the imaginary line, and that will give you roughly the anteversion. The real anteversion is measured only on the CT scan, and that is the way we do it on the CT scan. What we normally do, the CT scan is done from the hip to the level of the knee, and we do a superimposition technique, and this is available on every soft tissue, on CT scans, the software. So what we do normally, this is the knee, and this is the femur with a broadest portion of the neck, and we try to find out where is the epicondylar axis. So we try and put a line on the epicondylar axis and a second line on the maximum part of the neck, breadth of the neck. So two lines we draw, and that is the angle of real anteversion. That is on radiologically, and this is clinically. So another test is a Piriformis test. This is done in lateral decubitus position. Hip is flexed around 40 to 45 degrees. Knee is flexed to 90 degrees. One hand stabilizes the pelvis. The other hand pushes the knee to the floor, causing an internal rotation. So you can see that that is the hand there, and you are pushing this in adduction and internal rotation. The hip is forced into adduction and internal rotation. Patient points out the pain at the level of the trochanteric area, and that becomes a piriformis. I think it's an overwritten and overemphasized test. It's a difficult actually test, but this is one of the piriformis tendinitis tests has to be described. So next is your Patrick's test, which is mainly test mainly for the sacroiliac joint. And what you do in this case, you stabilize the pelvis for the opposite side and do the full abduction and external rotation. Put the leg on the opposite side of the knee and try to push and keep the pelvis opposite side. Yeah, you have to stabilize the opposite side. So any strain on the sacroiliac on this side, the testing side will be positive. That is a Patrick test. So this is mainly a stress test for sacroiliac. There are 3-4 tests which are described for sacroiliac. This is one of them. So mostly patient points out the pain behind, posterior to the sacroiliac area, just away from the midline. And this also is positive in arthritic hips, where they will get an anterior pain. So the next is the pelvic stress test. So put the patient on the lateral and push the from the trochanteric area, push the pelvis. So the patient will point out a pain at the whatever the right or left, depends on which sacroiliac is involved, or it can be a pubic area also. So the pelvic stress can be also sacroiliac, can be also on the pubic symphysis. That is a sometimes arthritic infection, subluxation possibilities there. Then the another is the anterior pelvic compression. So make the patient prone, and you do it from the where the sacrum area, midline, using the two hands. You have look at that, how you use the hands, like how you do cardiac massage. So that's the way you push. The anterior pain is pointed out by pelvic ring, because of the pelvic ring problem. So there is a possibility of either pubic diastasis or some form of erosion, or sometimes you have a subluxation, sometimes you have an arthritis of the post-infective arthritis, possibilities there of symphysis. And this is the anterior test for pelvic stress. You do it at the level of the symphysis. There is a possibility of ruling out some amount of infective or subluxation of the Stritchfield test. This is done with the patient supine, extend the knee, examiner resist active hip flexion to 40-45. Positivity elicits that is associated intra-articular hip pathology. There is a possibility of, this is a Stritchfield active resisted test of the hip. Then you have impingement test of anterior impingement and posterior impingement, which we talked on when we discussed the FAI, femoral acetabular, but still we'll repeat this test. This is for anterior impingement, flexion, adduction, internal rotation. Very classical. The patient will point out the pain in the groin area. So you flex the hip to 90 degrees, adduct to about 20 to 30 degrees, whatever the best is, and slowly internal rotate, and that the patient will point out the anteriorly. This indicates the femoral acetabular, anterior femoral acetabular impingement test. This is very classical test of anterior impingement. We have a similar test to the posterior impingement. Here we do slightly in reverse way. Instead of internal rotation and flexion, we do extension, external rotation. So bring the patient to the edge of the table, force in external rotation, extension, and that will produce the posterior impingement. And the patient, instead of anteriorly, will complain of the posterior. So actually anterior impingement is very common. Posterior impingement is not that common, but we need to do both the tests, especially younger patient with FAI. So this is a posterior impingement test. Most of the students forget the hip examination, neurological examination. They absolutely forget. It takes hardly 1 minute to test this neurological examination, because we do see with hip pathology lot of neurological patient, and if you don't examine during the surgery, these chances of these patients getting into dislocation is very, very high. Suppose patient is spastic, patient has something else additional, and you will miss this very commonly, which is done by most of the clinicians. So you need to take the knee jerk, ankle jerk, plantar babies. These are three, hardly takes any time. if I examine about 100 to 200 patients in my OPD, suppose in a month's time, I will be able to pick up at least one patient who has some neurological disorder. And that is important. That picking of one patient out of 200 or 100 patient is important rather than 99, looking at the 99 patient. So you need to examine neurological examination, ankle jerk, knee jerk, and if you have got any doubt, then you do a clonus, ankle clonus, knee clonus, and then you go into detail of it. But at least quick examination of knee, ankle jerk, and plantar is absolutely mandatory for you for neurological. And this is another important, all of you know that vascular. So all hip patients, you need to palpate posterior tibial, dorsalis pedis. If there is a doubt, just go proximally. As you go proximally, popliteal, then femoral. So you go from distal to proximal, one by one step ahead. So this is another very important documentation for as far as the vascular status is concerned. So neurological, vascular status both. Many patients, the hip, suppose you want to going to operate hip and if patient does not have a distal pulsation, you need to document. Then you need to go on a Doppler, then couple of other tests. Hip surgery may not be contraindicated, but it is important to document. Knee is very important. For knee, it is very important to for a dorsalis pedis or posterior tibial has to be possible. Any resident, what is the percentage of tibialis posterior positiveness in normal individuals? Anybody?
Yes, anybody?
What is the normal percentage of positiveness of tibialis posterior artery in normal population? Anybody?
98%.
Wrong.
It is 100%, sir.
100.
100%. What about dorsalis pedis? How many percentage absent?
Yes, anybody?
60%.
No.
No.
98%. That is 98%.
No.
7 to 8% innominate dorsalis pedis might be absent in the normal course.
Normal course, yes. 6 to 8% is normal population, and 100% it has to be dorsalis pedis has to posterior tibial has to be there. There is no abnormality in the anatomical abnormality. So this is very important for you. Somebody is going to ask you when you are going to hit a medal. Anyhow, this is fulcrum test, which is again rarely done. For a non-Indian femur, this is very commonly done. So you put exactly at the level of the fracture side, you put your hand, and this is a lever, actually is a lever type, and you try to push the knee down. If there's a non-Indian, there is either possibility abnormal mobility you will get, or you will get a pain. There is a possibility of getting this test done. So this is a fulcrum test especially for the non-Indian femur, nothing more. Not to forget the other lower limb. That is another possibility. Most of the time you are likely to forget the opposite hip examination. So I think it's very important to look at the opposite hip so that it is possible for you to compare. Don't concentrate after you are doing concentration. You must examine that. Spine, we already discussed. There's a very important spinopelvic relation. Nowadays, this is something new which Dr. Arvind Kulkarni also was pointing out that examination of the hip and spine has got a complete correlation. That is known as a spinopelvic parameter, something new entity coming up. For last 5 years, we have been looking into this entity, spinopelvic, which I am not going to go in detail, but for your examination, it's very important to know whether the spine is lordotic or whether spine is kyphotic. If it is kyphotic, there's something else. If it is lordotic, there's something else which we will have to, which we will talk sometimes with the spinopelvic parameter when we discussed. Abdomen mainly lower. This is when patient has got a spasm of the iliopsoas, or patient has got a flexion deformity. Patient has got a kyphosis, lumbar kyphosis. So you got to put a hand on the lower abdomen in the iliac fossa. There is a chances of these patients having abscess, iliopsoas abscess, maybe tubercles. So I think lower quadrant examination of the is important to complete your examination. If you don't, patient with a flexion deformity, adduction deformity, you are not going to put the hand on a kyphotic patient. You are not going to put on the lower abdomen with the iliopsoas abscess, big tense abscess possibility. You are going to miss the whole bus. I think per rectal examination, I think for completion, if somebody asks you, sir, there is a, especially in central fracture dislocation or any pathological condition, I think we'll just mention, so there is a that per rectal examination I have not done, sir. Why? They will ask you, so you will have to explain that there is 1, 2, 3 important points per rectal examination. But you, lastly, if they ask anything you are missing, then you can just tell you it's a per rectal examination. Then there is a test for ankylosis of the, whether it's a sound or bony ankylosis. One test has been described. I don't know whether it is in the literature is there or not. I am not very sure, but this is the test. One of the examiner may ask you for a fibrous ankylosis or bony ankylosis. This test can be easily performed, very easy way. So this is, I'm talking about the hip. Palpate one hand on the adductor tendon, adductor longus tendon. Put a hand on the adductor, the index and the middle finger, just to palpate that area, palpate the area. Second hand put on the knee, lower above the knee, just on the femur, and gently abduct the hip. If the adductor gets contracted, that means it is an unsound ankylosis. If adductor does not get contracted, that means a bony fusion has taken place. Why? Because if there is a bony fusion, the muscle does not transmit any action. So that is the basic principle of an ankylosed hip. So if there is a bony ankylosis or a firm ankylosis, this test will not be positive because there is no contraction of the adductor will be there. So we can differentiate, and also if there is a fibrous ankylosis, patient will have pain. Here in a bony ankylosis, patient will not have any pain. So forceful abduction, putting a hand on the adductor and palpating the adductor tendon. If the adductor gets contracted, that means it is not a bony ankylosis. It is either a fibrous ankylosis or there is no ankylosis there. So this is the way it is described between the sound ankylosis and unsound ankylosis. Same thing is possible in elbow. In a flex elbow, in the ankylosed elbow, you put a hand on the biceps here, bicep, and extend it. Forcefully extend. If the bicep gets contracted, that means the ankylosis is not sound because the transmission pulsation is there. So that's the way we examine between the sound ankylosis and bony ankylosis. I don't know whether it's described in the book or not. Srigunj, this is described?
No, sir. No. In any examination book, this test has not been described.
Okay. So that's all the tests are. Anybody want to ask anything? Please go ahead.
Yes, somebody was having any doubts who written in chat. Please proceed with your question. Anybody?
Hello, sir. Hello.
Yes, proceed.
Sir, how to differentiate between sound and unsound ankylosis, sir? Is it a pain or anatomical position?
No, it is both the things. It is if the contraction occurs, that means it is unsound. And that with that contraction, if the patient has got some minor pain, he will complain. But in a firm fibrous, some part of the ankylosing, he may not complain. But if any adductors are getting contracted, that means it is an unsound ankylosis. Sometimes firm fibrous ankylosis may not produce pain. So we have to consider both pain as well as the contraction of the muscle.
Okay, sir. Thank you.
Because Transmission
Yes.
does not take place in a full ankylosis. That's a basic principle.
Okay, sir.
Yes, any
Will
other
apply to
question?
any ankylosis.
Yes, sir. Yes, sir. Proceed, sir. Sir, you were saying something.
No, nothing.
Okay, okay. Yes, anybody having any other doubt, please proceed.
What I want you to do this is a repeated examination of the patient. You are at least you have to do a 50 to 100 hip examinations. You do again sequential continuously, then you will become a master in this. And history taking, I told you, is an art, and you just do it repeatedly. And it becomes so very easy if you just do a formula, something like a examination, and as well as the history taking. So don't get frustrated, because most of the time what happens, most of the time the students are going and just they have done examination only 1 or 2 hips and they are straight in the exam. It is just not possible. You have to minimum 100 examination of the hip, and you have to present to either to your colleagues or to your subordinate or to the seniors. Go on repeating. Hip, spine, these are the two things you have to do it again and again, because you are 50% of you are going to get either spine or hip in the long case.
Yes, sir. Absolutely. Practice. Every resident should practice at least 50 to 100 case of hip and spine examination, and repeatedly present in front of your colleagues or seniors. And then only you will be having confluence in exam, because the examiner easily judges that this boy has presented 2 to 5 case and this boy has presented 50 to 100 case. It makes a real difference. Yes.
Yes.
Any other doubt?
And you will get a flow of examination, you will flow of talking. Very important.
Yes, sir. Yes, sir.
And use common sense again. I told you 3-4 times. I told you, use some common sense. You are not these tests and plus clinical finding. You try to match them sometimes,
Yes, sir.
and
Yes,
don't
sir.
make a mistake of adduction deformity and abduction deformity and flexion deformity. The examiners are very choosy. I don't know why. But they are very choosy of deformities and measurements also. They are very choosy about this, and also they are very much gait. So try to master actually gait. And there are only 3-4 gates. There is nothing major, I'm telling you. You
Yes,
have
sir.
an antalgic gate, you have tentacle gate, you have a modeling gate, you have a short limb gate, and you have a circumduction and other 2-3 gates. Nothing major in that. I'm telling you why. I don't know. You get confused. And again, I told you one more important in a tenderbutt test is kept the knee flexion and hip in neutral or whatever the amount of deformity. If you allow the patient to flex the hip, it will block the pelvis and you will get a false. And many examiners will like that you tell them. Many examiners also don't know that hip is not to be flexed. When you look at the actually Das book, very crystal clear he has given the figure.
Yes, sir. Yes. Any other doubts?
And don't make the patient lie down on the floor at any cost. Even your coach is not good, so you tell the examiner, I'm sorry sir, this is not a hard bed, but I got to I would like to examine, actually ideally will be this karke. But don't make the patient lie down on the floor.
Yes, sir. Yes, sir.
And sometimes if you don't know, you straightway tell them, sir, I'm sorry, I don't know this test. So at least they can proceed further, and they can examine the other, rather than then they get stuck to the one, and then your viva is over in that only.
Yes,
And
sir.
don't put any rare diagnosis. No rare case will be kept in the exam. No rare case.
Hello, sir.
Don't put diagnosis at all.
Yes, sir.
Something
Yes,
like
anybody?
you will feel like a synovial chondromatosis or something like that rare, you know.
Yes, sir. Yes, sir.
Hello, sir.
Yes, yes. Proceed with your question.
Sir, I have a doubt. I want to ask that till what age we can do Ortolani and Barlow test, sir?
Ortolani and Barlow, I think maximum is about maximum 1.5 to 2 years. Ideal is neonates. Less than a year or so.
Sir, I have one doubt, sir.
Yeah.
Sir, in case
Go
of subtrochanteric fracture with a abductor lutz, sir, should we go for an valgus osteotomy? Valgus osteotomy, we have to tell as the final answer, sir.
No.
The patient is already 75 years age, sir.
Subtrochanteric, out of question to do valgus osteotomy. Subtrochanteric is a different entity itself. You can do it for intertrochanteric malunited fracture, not for subtrochanteric.
Okay, sir.
For intertrochanteric with coxa with malunion, then you can do abduction osteotomy just below that, but you can't do it for subtrochanteric fracture.
In case of a subtrochanteric fracture, sir, what is the best surgery for a adult, sir?
Sorry?
I got this case in the I have asked like for a subtrochanteric fracture, what surgery will you do? It is a 75-year-old male, sir, with an abductor lutz.
Yes, if it is a subtrochanteric fracture and which is not operated subtrochanteric, then you can use there are 2-3 devices you can use for subtrochanteric, depends on what level of the subtrochanteric fracture is. Whether it is within 5 centimeter or very close by, then you can put either proximal nails with, sometimes you have to use a lateral small plate to stabilize the proximal fragment, and bone grafting is very important for subtrochanteric fracture. If you have good fragment, you can use the condylar plate and as well as the bone graft. So you require almost like a composite type of fixation with subtrochanteric fracture. And if he's already operated subtrochanteric fracture, 1 or 2 surgeries are already done. Don't do third surgery. Best is to replace with a proximal segment. So you have to do a hip replacement with either proximal segment or some other type, depends on what type of, where exactly is subtrochanteric nonlinear. If it is twice it has failed, twice has failed already, implant, the bone graft, don't do third surgery. It will be again failure.
Sir, actually, the case is a malunited subtrochanteric fracture, sir. I'm sorry, I didn't give it exactly, sir.
Malunited is a different entity.
Yes, sir.
Malunited is a different entity itself. Then you can do a corrective osteotomy. You can do corrective osteotomy and do a fixation. Corrective osteotomy can be done for malunion of the subtrochanteric fracture. If it is not united, there is a different picture. It is malunited, you can do a corrective osteotomy at the level and then correct the both alignment, whether it is in flexion or whether it is in water rotation, so you can correct it. Yes, you can do that correction.
Okay, sir.
Hello,
Thank
sir.
you, sir.
Okay. Sir, one last doubt, sir, I want to know.
Yes, proceed.
Sure.
Sir, what are the differences between intertrochanteric femur fracture and intracapsular neck of femur fracture? Sir, they have asked this question during my practical also. So, sir has asked me that tell me about 10 differences what you can tell. So, I was able to only answer few of them, but not completely, sir. If you can enumerate complete of them, sir, it will be very helpful.
They are talking about clinical or radiological?
Sir, clinical, sir. based on from history to clinical part, like that they have asked, sir.
Yes. Uh, they were asking for the on the clinical ground,
Yes, sir. Yes, sir.
intertrochanteric and transcervical.
Yes, sir. Yes, sir. What will be the differences between them? If you can enumerate like that, they have asked.
Basically, you start with basically we start with the transcervical and intertrochanteric fracture when the patients are coming to the hospital. Okay.
Yes,
Now,
sir.
uh, IT fracture, where you have to start with whether the patient had a trivial trauma or a very severe trauma. If it is a transcervical fracture, usually is a trivial trauma, very minor trauma, and most of the time they are elderly patient with a very minimal trauma. For intertrochanteric, they require a major trauma. That's the first difference of what type of injury patient has. Next number is whether there is a male or female patient. Male or female patient. So females usually more common with a transcervical fracture because of the severe osteoporosis. That is another one important finding. The transcervical fractures are very common in females rather than a male patient because of the osteoporosis. Then the third important factor where they find out the comorbidity of the patients. What type of morbidity patients usually have. The next important finding is what is the when the patient is lying down, what about the amount of shortening patient has. If the intertrochanteric fracture is a much more shortening is much more than the transcervical fracture. The another important is what is called telltale sign. If you look at the expose the area, you will see a lot of ecchymosis, but which is not there in transcervical fracture. That is another important finding clinically. So a lot of ecchymosis. Then the edema and the soft tissue in the intertrochanteric fracture is much more as compared to transcervical fracture. And if this is an impacted transcervical fracture, you may not get shortening. So you ask the patient to lift the leg, they are able to lift the leg. But in a non-impacted, they will not be able to. Intertrochanteric patient will not be able to lift the leg. Active SLR, FT abduction, not possible. But in impacted fracture, many patients will come walking with some degree of limp. That is another important finding, very important local finding. In impacted, they will be able to do SLR, but otherwise they will not be able to. Intertrochanteric, out of question to do any SLR. Then you have marked external rotation deformity in case of IT fracture. Transcervical, you may not have that amount of external rotation. Then pain factor is very much IT fracture is very painful because there's a massive injury has taken place. TC fracture, the amount of pain is not that severe. That is another important. Then your radiological things are there. These are the couple of things which you can put it into between the IT fracture and a DC fracture.
Thank you,
Some
sir.
examiners have their funny ideas, so I think you have to accept it.
Sir, yes.
And one more point, sir. Usually they write in books that usually neck of femur occurs in 6th decade and IT occurs in 7th and 8th decade. Usually.
Yes, that I told you. The age I told you.
Yes.
Age group, yes. Age group, gender.
Yes. Any other doubts? Okay, sir. So we end this lecture here, sir. And
Yes.
and thank you very much, sir, for your time and effort, sir. You make hip examination very clear. The lecture was in detail, and you make it absolutely very clear. Thank you very much, sir.
I know
Thank you, sir.
you people have to repeat again and again, because
Yes.
this is one just examination may not be adequate. So you will have to, on the YouTube, this is there, go on repeating, go on again and again, and
Yes,
do a
sir.
lot of discussion between yourself, between your colleagues. That is the only way getting a master. And just what you do, you actually should present to each other. Then only you will know that this is something going wrong. So that is the only way to find out.
Yes, sir. Yes.
Okay.
Okay, sir.
Thank you, sir.
Okay. Thank you very much, sir. We are ending this lecture. Good night, sir.
Thank you, sir.
Good night.
Good night.